In part 2, we saw something important. Heart attacks do not begin suddenly. They build silently, inside arteries, without pain, without warning. So the real question is this. If the process is silent, how do we detect it? Before damage happens? That is where blood tests enter the story. Most people wait for symptoms. Chest pain, breathlessness, fatigue. But symptoms appear late. By the time pain begins, arteries may already be significantly narrowed. Blood tests are not about diagnosing pain. They are about predicting probability before symptoms ever appear. A blood test does not say, "You have a heart attack." It says something more subtle. It estimates risk. Think of it like weather prediction. Clouds do not guarantee rain, but they increase probability. High LDL does not mean blockage today. It increases the chance of blockage tomorrow. That difference matters. There are 4 core signals that predict heart risk: LDL, HDL, triglycerides, and inflammation. Together, they tell a story, not about today, but about what your arteries may look like years from now. Let's understand them clearly. LDL is often called bad cholesterol, but that name is incomplete. LDL is a carrier. It delivers cholesterol to cells. Cholesterol itself is necessary, but when LDL levels rise too high, more particles circulate. More particles increase the chance that some will enter artery walls. Risk increases with quantity. Think of LDL like cars on a highway. If only a few cars drive, accidents are rare. If traffic increases, collision probability rises. Lower LDL means fewer circulating particles. Fewer particles mean fewer opportunities for arterial entry. It is a probability game, not a moral judgment. HDL works differently. It acts like a cleaning crew. It collects excess cholesterol. It carries it back to the liver. Higher HDL improves removal efficiency, but HDL alone cannot compensate for extremely high LDL. Balance matters. Delivery and cleanup must remain aligned. Now let's connect cholesterol to sugar. When you consume excess sugar, your body must process it. The liver converts extra glucose into fat. These fats are called triglycerides. They circulate in the blood. High triglycerides often mean excess sugar intake. They also reduce HDL and increase small, dense LDL particles, which enter artery walls more easily. Sugar and cholesterol are deeply connected. Not all LDL particles behave the same. When triglycerides rise, LDL particles become smaller, denser, more aggressive. These small, dense particles slip into artery walls more easily. They oxidize faster. They trigger more inflammation. So triglycerides are not just fat numbers. They change the behavior of cholesterol itself. Many people look only at total cholesterol, but that number can mislead. Total cholesterol is a combination. It includes LDL, HDL, other particles. You can have normal total cholesterol, but high LDL, low HDL, high triglycerides. The total may look fine. The pattern may not. Patterns predict risk. Doctors often look at ratios because relationships matter. LDL compared to HDL, triglycerides compared to HDL. If delivery overwhelms cleanup, imbalance increases. If triglycerides are high and HDL is low, insulin resistance may be present. Single numbers or pieces. Ratios reveal interaction. Biology works in relationships. Sometimes numbers fall into borderline ranges. Not clearly high, not clearly low. This is where many people relax. But moderate abnormalities, over many years, can still cause plaque. Risk is cumulative. Small imbalance, repeated daily, over decades. That is how silent disease grows. Now we go slightly deeper. Each LDL particle has a protein called ApoB. ApoB represents particle number. You can have normal LDL cholesterol, but many small particles. More particles mean more opportunities to enter artery walls. ApoB measures count. Sometimes count matters more than content. This is advanced risk detection. Cholesterol alone does not cause rupture. Inflammation amplifies danger. When artery walls remain inflamed, fibrous caps weaken. Plaque becomes unstable. Inflammation markers, like hsCRP, help estimate this risk. You can have moderate cholesterol, but high inflammation. That combination Increases vulnerability. Risk is not one number. It is interaction. Blood sugar does not only affect today. It leaves a memory. When glucose stays elevated, it attaches to hemoglobin. This process is called glycation. HbA1c measures how much sugar has been attached over several months. It is not a momentary number. It reflects average exposure. Higher long-term sugar means more vessel stress, more inflammation, more plaque vulnerability. This is how diabetes multiplies heart risk. When sugar remains high, artery walls change. Proteins become stiff. Elasticity decreases. The endothelium loses flexibility. Inflammation rises. LDL enters more easily. This is not visible outside, but inside, chemistry shifts. Sugar quietly changes structure, and structure determines stability. Now add pressure. Blood pressure is mechanical force. When pressure rises, artery walls stretch repeatedly, like bending metal wire. Again and again, small injuries form. The protective lining weakens. LDL enters more easily. Inflammation increases. Pressure does not create plaque alone, but it accelerates damage. Mechanical stress magnifies chemical stress. Risk rarely comes alone. Moderate LDL, slightly high sugar, borderline blood pressure, mild abdominal fat, each alone may not seem alarming, but together, they multiply. Risk stacking is more dangerous than one extreme number. Biology responds to total load. Genetics influences baseline risk. If heart disease appears early in family members, screening should begin sooner. Genes may affect cholesterol metabolism, inflammation levels, vessel structure, but genes are not destiny. They adjust probability. Lifestyle still shapes outcome. Risk exists on a spectrum. Low risk means stable numbers, and healthy habits. Moderate risk means imbalance. That requires correction. High risk means active vulnerability and possible medical intervention. Categories guide decisions. They do not label identity. They guide prevention strategy. In low to moderate risk, lifestyle can be powerful. Regular movement, balanced nutrition, stable sleep cycles, stress regulation, consistent monitoring. Biology responds to consistency. Inflammation decreases. HDL improves. Triglycerides fall. Plaque stabilizes. Prevention is daily action. Sometimes lifestyle is not enough. Some people inherit strong cholesterol production, even with good habits. LDL remains high, or plaque has already formed. In moderate to high risk, medication may be necessary, not because lifestyle failed, but because biology requires stronger intervention. Prevention sometimes needs multiple tools. Statins reduce cholesterol production. Inside the liver, they lower circulating LDL particles. Fewer particles mean fewer entry attempts into artery walls. They also reduce inflammation within plaque, which helps stabilize the fibrous cap. They do not erase plaque. They reduce rupture probability. Understanding mechanism removes fear. Needing medication is not weakness. It is strategy. Just as glasses improve vision, medication can reduce biological risk. The goal is protection, not perfection. Lifestyle remains foundation. Medication becomes reinforcement. Together, they lower long-term danger. Regular monitoring keeps risk visible. A lipid profile shows cholesterol balance. Long-term sugar testing reveals metabolic stress. Blood pressure shows mechanical strain. Inflammation markers estimate instability risk. Testing does not create fear. It creates clarity. One test is a snapshot. Multiple tests form a movie. Trends reveal direction. Is LDL slowly rising? Is sugar creeping upward? Is pressure increasing yearly? Small upward trends predict future risk. Early correction is easier than late repair. Heart disease rarely begins in old age. It often starts decades earlier. The earlier you check numbers, the easier correction becomes. Small changes at 30 prevent major problems at 60. Prevention is simpler than emergency treatment. Time is the strongest advantage. In heart protection, this was part 3. We moved from plaque formation to risk prediction. LDL shows delivery load. HDL shows cleanup strength. Triglycerides reveal sugar excess. Inflammation signals instability. Pressure adds mechanical stress. Risk is not sudden. It is calculated, measured, and modifiable. If this series made complex biology simple, like the video, subscribe to continue learning step by step. Share this with someone you care about. Understanding today can prevent crisis tomorrow.